Welcome to the Prescription for Admission podcast, where we talk about hospitals and hospital-based care, who you can expect to meet, and what you may experience during your time in the hospital, both as a patient and also as a healthcare provider working in a hospital. My name is Dr. Monique Nugent. I am a practicing hospitalist and also the author of Prescription for Admission, the book, where I talk about many of the same topics. Thank you for joining me and enjoy the show. Hi, and welcome back to another episode of the Prescription for Admission podcast with me, your host, Dr. Monique Nugent. I am a practicing hospitalist and also the author of Prescription for Admission, the book, where I talk about a lot of these same topics. But I have so much fun here on the podcast because I get to dive into things with experts and friends and have full conversations about my favorite thing, hospitals, all things hospitals. Your experience as a patient, as a caretaker, as a healthcare provider, working in a hospital. And today we're here with Dr. Evan Nadler. Dr. Nadler, thank you so much for joining us today. So he's part of
my pleasure.
Yeah, he's part of my favorite thing to do, which is invite pediatrics specialists and pediatricians who work in hospitals to talk about the experience of being a parent, being a child in a hospital setting, which is very different from where I work in the adult wards. And so, Dr. Nadler, thank you so much for joining us.
Yeah, thanks so much for having me.
Yeah,
Always happy to talk about kids and health.
Yes, so we've got a lot to cover. I'm just going to introduce Dr. Nadler because he's quite impressive. Dr. Evan Nadler is one of the nation's leading pediatric bariatric surgeons who has a mission of treating children with obesity for over 20 years. Now he is on a mission to help both children and adults overcome obesity with expert care, education, and innovative solutions, with a goal to transform the lives of the over 100 million people battling the disease of obesity. He's currently writing a book, he has a YouTube channel, and has started a pediatric telemedicine weight management practice to help address the gaps of access to care nationally. Dr. Nadler, Evan, thank you so much for being here and for your time. So,
again, great topic for me. I love to talk about this stuff.
Yeah. So I always like to start with a bit of your professional story so that the students or anyone considering going into medicine, the residents, including who may want to specialize, know how you built your career, how you got to this point, how you thought about going into pediatric bariatric surgery. So how does one become a pediatric bariatric surgeon?
Yeah, by accident is the short answer.
That's actually the most common answer I get.
Yeah. So, maybe now it's different, but so, when I was thinking about being a pediatric surgeon, it was never to necessarily treat teenagers with obesity. It wasn't even really on the horizon for anybody back in, I did my pediatric surgery sort of research years in 1998 to 2000. So long time ago. But I had a sort of an epiphany moment, which I think was in 2000, although as we get older, the dates get more wonky in my head because I can't remember things like I used to. So that's, I think, a common problem for most of us as we age. But I sort of had an epiphany moment in, I think, 2000, where I was at a pediatric surgery national meeting, and I was presenting my research data, which was totally unrelated to obesity. And it was in Disney, and it was in May. It was at Disney in May. And I remember being at the pool between the Dolphin and the Swan. For anybody who's been to Disney and knows the hotels there, those are two of the old school hotels. Big pool in between the two. And I remember just sitting there with my wife, and it was hot as all get out, and looking around the pool, and just the number of people at the pool who not only had weight issues, but were not necessarily eating the healthiest things, because Disney's not the healthiest place to eat. And then there were a lot of kids, same story. And I remember saying to her, someone has to be thinking about what we can do to help America get healthier, because this weight problem is just, getting out of hand. And then by happenstance, during my pediatric surgery training in 2003 or 4, one of my mentors was invited to join a group of the initial pediatric surgeons who were thinking about doing bariatric surgery in kids. So I was exposed to that as a fellow. and actually did my first case as a fellow. And then so my mentor decided I'm never going to treat children with obesity again because it's too hard. And I took the exact opposite tack, which was, this is what I need to do for my entire academic career because there's got to be a better way to help these kids, and I'm going to try to figure it out. So sort of by accident, and then 20 years of super hard work trying to change the way the world thinks about childhood obesity. And I'm still fighting that fight today, which is why I'm no longer full-time pediatric bariatric surgeon, but now doing these other things like writing a book and starting a telemedicine practice and going on podcasts and other things that are trying to take the message directly to the patients. I've been taking the message to the docs for 20 years, and now I think it's time that I go right to the people because they might be able to push the needle or move the needle more easily than the docs can.
Yeah, no, I get it. That's why I'm here talking about inpatient care or hospital care. I, spent all my time in hospitals building, thinking we can make the situation better from the inside. And I think there's a lot of us who now come to understand how much this information needs to be shared on both ends.
Yep.
Patients and also healthcare providers and the institutions that support us. So you did general surgery residency and then a fellowship in pediatric surgery and then further training in bariatric surgery.
Well, no, sort of. During general surgery residency back then and still now, lots of people take 2 years off to do basic science research with a pediatric surgeon somewhere to basically get a better application because pediatric surgery is still amongst the most competitive fellowship matches that are out there for general surgeons. So I did that. But then when I finished my pediatric surgery fellowship, my first hospital I joined, university I joined, was NYU, where they already had a really big and busy adult bariatric surgery practice. So rather than do formal training in bariatric surgery, I just basically hung out with those guys in the operating room while I was doing everything else at the same time and sort of just learned how to do it with them as opposed to some formalized training. So, yeah, I didn't really, because it was so long, again, that was in 2000.
It was so new.
It was so new that people didn't really know. And quickly I became more experienced than anybody else in the country, so it wasn't like I wasn't going to go back and do formalized training. So I've never actually had formalized bariatric surgery training, for what it's worth.
So it's interesting because as medicine changes, things change, things become new. So like me as a hospitalist, I did residency and then I was like, I am a hospitalist. I just decided to be a hospitalist. But now there's talk of that becoming a fellowship, like a real, you have to apply for fellowship. There are fellowships for hospital medicine that are not required to call yourself a hospitalist. But again, that field of hospital medicine, people didn't really think of as worthy of a fellowship until kind of now. We didn't really think that it was these acutely ill patients, this like time in someone's life where you're very sick is a very different experience from how we treat patients at other times, right? And so kind of the same thing with you, what you were saying, that maybe the need wasn't there. And as you're coming up, you're growing with the need. And now the need is there. And now the tools are there to train more people, thankfully to your research, to your experience, to you being in different places to say, hey, these type of patients need our care. And I think that's one of the cool things about medicine is how much it changes and how much you can be part of that change.
Yeah. And so in the adult world, there are now acute care surgeons, which, when I was training, like everybody was an acute care surgeon. Like, what did that mean? Like, of course you did acute care surgery but as you're sort of pointing out, the needs of the patients who need something acutely, take your pick what surgery it is, or just surgical critical care, that skill set needs to be more, to provide best care, that skill set needs to be more developed than it used to be because patients are sicker and there are more things going on. And so the general surgeon who has a busy elective practice may not be the best person to provide the acute care surgery when the patient comes to the hospital. So we haven't really gotten that way in peds yet, but I do sort of think about it and wonder whether at some point it could go that route as well. So right now, pediatric surgeons just do it all. But in the adult world, yeah, there are acute care surgeons who are basically surgical hospitalists, for lack of a better term. And I think it does improve. It likely improves the care that people get, because the people who are doing that surgery, it improves the care that people get while they're in the hospital, because the surgeons who are doing that, providing that care, doing those cases, are specifically sort of interested and or trained in caring for those patients. So I do think it probably is progress.
Yeah, it's kind of the same thing that we also see, that there are laborists now. So obstetricians who just they're just
That's
here
a term
in the hospital.
I just learned that term today.
You just learned that you're a laborist. Yeah.
Yeah. Is that a thing?
It's a
Did
thing.
you just make that up? That's a thing?
Yeah, it's a thing. I think more and more we come to understand that the hospital is like a place of different needs. I remember like years ago, one of our nocturnists was tapped on the shoulder by a reporter who had never heard the term nocturnist.
Which, again, neither have I, and I now think you're just making words up.
No, just
No, I think you're just spewing things out of your mouth.
Yeah.
No basis in reality.
So she was like, what is a nocturnist? So a nocturnist is a hospitalist who only works at night.
Got it.
Why? Because people like me refuse to work at night. I graduated residency and I said, I will sleep in the bed of my choosing every night that will not be in a hospital. And also the things that go on at night are just very different. Like there's tons of cross cover, there's admission versus what I do in the day, which is family meetings and talking to specialists and stuff like that. And so this reporter was like, wow, what is that term? And then when she found it was like a night doctor, didn't think it was that more interesting. But, there's more.
That, well, the nocturnists are also like vampires.
It's a different skill set, and it's a different social skill set. Sure. And so there's a place for all of us, but there's also a way each of us can grow the field, and each of us can be a part of the ongoing change of how not only we're supporting patients, but how we're supporting ourselves as well, and how we're developing our professional skills. And Evan was, right there learning and really kind of pushing the field of pediatric bariatric surgery. So I'm going to ask you just to define what bariatric surgery is for those of us who may not know.
Sure. So it's had a few different names over the years. So people might know the term bariatric surgery or might not. They might know the term weight loss surgery, but we don't like to use that term because it's not about weight loss. It's about gaining health. So it minimizes the disease of obesity and the patients who are undergoing a procedure to call it weight loss surgery. Again, although that might be a colloquial term that people recognize. And then the societies, like the big society for bariatric surgeons is called the ASMBS, and it's the American Society for Metabolic and Bariatric Surgery. So a lot of people call it metabolic surgery or metabolic and bariatric surgery. But what it really boils down to is there's sort of 2 or 3 common procedures that are done. One is the gastric bypass, which sort of started the whole field, and people, again, might know about that surgery. And when that surgery became popularized back in the 1990s, it had a fair number of complications and was done technically differently than it's done today. And so it kind of got a bad name and a bad rap that I think has persisted over time. So I often try to make sure people understand that bariatric surgery is different than gastric bypass, and certainly different than gastric bypass from the early 2000s, let's say. But gastric bypass still does make up about 25%, 30%, some number of the operations that adults get. But it's now done laparoscopically, which means 5 small incisions and shorter hospital duration stay and less complications and easier recovery. And so there have been a lot of advances over 20 years. But the procedure that's sort of taken over as the most popular procedure is something called the laparoscopic sleeve gastrectomy, which is a much simpler and quicker operation than the gastric bypass. And it basically consists of, again, 5 small incisions, but we use a stapling device and remove about 80 to 90% of the stomach. And that makes up about 70% of what adults get, and actually makes up probably close to 99% of what kids get, just because it has less nutritional complications. And then there's some advanced procedures like biliopancreatic diversion, which is for people who have much higher weights and much greater need for immediate surgical help with their metabolic issues. The lap band, people might remember from back in the day, that's sort of gone by the wayside. And then, there are all kinds of newer devices and developments that are starting to enter the field, like intragastric balloons and some endoscopic procedures. But for the most part, metabolic and bariatric surgery really means laparoscopic gastric bypass, laparoscopic sleeve gastrectomy, and some other revisional procedures that are done in small numbers.
So before you were a bariatric surgeon, you were a pediatric general surgeon, right? And you still are. And so you have patients who come to see you, make an appointment to see you, and then they go to the hospital and see you. But then there were also maybe patients who showed up in the hospital. So I had the opportunity, I had a child who needed a hernia repair, and I went the route of finding a surgeon. And the way I found a surgeon was I called my friend who was in fellowship, and I said, Ivan, do you know a good pediatric surgeon up here in the area that I live in? And he said, give me 2 days, I'll get back to you. But that's not the way that people find pediatric surgeons. So what advice do you have for people who maybe the parents and the children who are coming into the hospital and need to see a surgeon, and you're the surgeon on call, right? What is that like navigating a pediatric hospitalization that requires surgery? And then also, how do we find a pediatric surgeon as parents? If our pediatrician says, you guys need a hernia repair, you guys need a X, Y, and Z, how do you find a pediatric surgeon?
Yeah, so there are two very different questions. And I think probably the scariest hospital experience for people is probably being the parent of a newborn child who needs surgical care. So you're in the NICU, your baby's in the NICU, let's say, the neonatal intensive care unit, and the neonatologists tell you that your child needs surgery. Or maybe you even had a prenatal diagnosis if you had prenatal care that suggested there was a problem. And generally, you have no control or say over who that surgeon is going to be. It's going to be somebody who works at that hospital, who happens to be on call that day, and comes to see you. And depending on whether you're at a teaching hospital or not, it can be residents, fellows, attending surgeons, or all of the above. And I often think about how scary that must be for the parents. Obviously, the baby doesn't really know what's going on, but the parents are navigating a situation that they probably had no idea they were going to be in, or maybe they did know because of the prenatal diagnosis, but didn't really know what that was going to be like, because you can only anticipate so much without having actually go through it. So that I try really hard when I'm in those situations to try to put the families at ease as best I can. My personal style is to try to identify with the family in some non-medical way. Like if I see the family's wearing a sports jersey, the first comment I might make to them is, oh, you like the Dallas Cowboys? I hate the Cowboys. Or something that like shows them that I'm a human, just like they're a human, and that we're, just here together to try to do what's best for their baby. And then obviously you have to try to explain to these families what the condition is and what the likely procedures that may or may not be required and what the likely outcomes are. And, and then you just sort of develop a relationship with the family. And that's sort of I would say the common scenario or pathway for babies who need surgery. Now, that's different from your situation when your pediatrician found a hernia in your child and said you needed a hernia repair. And then the other sort of common scenario is your child has appendicitis. Your child has right lower quadrant pain for a day or two, and you bring your patient to your pediatrician examines them and says, oh, you need to go to the hospital, and then you're in the ER. And again, you're sort of like helpless in that ER because you don't know what to expect. You don't know what's going on, And again, I'm sure and that situation is both stressful for the family, but also for the kid, because usually the kid's old enough to understand what's going on. And in that emergency room scenario, again, you have very little control over your pediatric surgery choices. In your situation, when your pediatrician says your kid needs a hernia, or let's say your pediatrician says your kid needs a belly button hernia, or take your pick of sort of elective or semi-elective surgical procedures, usually the pediatricians have some referral network or some guidance that they can provide for the families. But if they don't, then, and it's on the family to find somebody, that's sort of a situation where I don't want to say go ask your chat bot or Copilot or Chat GPT, but the reality is you have to go, like if you live in Washington, D.C., where I live, or Boston, where you live, you might have to enter into Copilot or take your pick which search engine you want to use, Gemini. We're non-discriminating here. We accept all AI platforms. You might have to put in, who's a good pediatric surgeon in the Boston area? Because I don't actually know how else one would go about doing it. Yeah, if you have friends who are in the business, or or relatives, or some connection some way or another that can help you. But otherwise, there isn't really a great, so the American Pediatric Surgery Association is the big pediatric surgery professional association. And they have a website, and there's a link for families where you can search pediatric surgeons in your area. But that's clunky, right? And not everybody knows, no one knows the American Pediatric Surgery Association. Like that wouldn't come off the top of your...
It doesn't tell you who's covered by your insurance either.
Well, that's true too. So you could go into your insurance provider's manual or whatever, or website. It would be useful if there were an easier way to do it for people, both in the pediatric world and frankly the adult world. People who I know ask me, hey, do you know a good general surgeon in DC? And I'm like, no, because I'm a pediatric surgeon and I don't know who they are. I don't know who the adult surgeons are. And I'm thinking to myself, if you're asking me, you're already in tough shape, because I should not be the person you're asking. You should be asking your primary medical doctor, or like someone who might know some adult providers. But yeah, it's a good point that you bring up, and the wheels are spinning in my head as to why aren't there better ways for people to find.
How many, if you don't know this answer, I just came up with this question, but how many pediatric surgeons are there
in the country?
Yeah.
Yeah, I used to know that number better than I do now, but I think at one point there were 1,000 or something. So it's a relatively small number.
The answer might be you might not have a choice, because whoever's in your area might be one of few people in your area.
Well, the issue with pediatric surgery, which is accentuated actually with pediatric weight management programs, is it's very variable geographically. So if you live in New York City, you can go to pediatric surgeons at NYU, at Columbia, at Mount Sinai, at Beth Israel, take your pick. There are a bunch of hospitals, they all have pediatric surgeons. If you live in Montana, there are no pediatric surgeons who actually, well, I take that back. I think there are 2 pediatric surgeons who are full-time in Montana for the entire state.
And the whole
state.
If
you don't live anywhere near those people, because they live up near Glacier National Park in the very, up near Canada, then you may not have a choice. In fact, you may actually be told you have to go to another state to find pediatric surgery care. So it's there are too many pediatric surgeons in high-density places and too few high-density population places, and too few in other regions where population density is not so great.
Yeah.
And then again, that's even worse. If you look at weight management, pediatric weight management or pediatric bariatric surgery, it's even worse. The states that need it the most are in the Sun Belt, the Southern, the Bible Belt, and that's the place where there are the fewest pediatric bariatric surgery programs that exist. So it's just a disconnect of the whole medical system that we're not likely to solve during this podcast, but
You don't think so?
no, I don't think so. But it's a problem. And actually, one of the reasons we started our pediatric telemedicine weight management program is that you no longer have to drive 2 hours to see somebody if you live in a place that's not close to anybody. So,
Yeah. No,
I,
that's a discussion that I'm definitely going to have as well, is like health equity outcomes. It's not just, people often think it's woman, man, black, white, old, young. There's so many things that lead to disparate outcomes, and your physical location where you live is one of them. Right.
for
And I
sure.
think we have this conversation probably in the public is more aware of it when you talk obstetrical care, because people talk about having to drive 2 hours to deliver, and then there's a viral video of a woman delivering in a car, so that's like a thing people talk about. It's like, oh, there's no obstetricians in these rural areas. But really what you're hitting the nail on the head is there's no care. It's not just babies that need to be born. Kids will get appendicitis. Somebody needs care for their obesity. Nana needs to be supported with physical therapy in a nursing home. Like, your physical location is one of the things that can drive disparate outcomes. So, yeah,
That can even be true in urban areas. Like, my partner in my telemedicine program is from Atlanta, and she talks about how people who are south of Atlanta will not drive into Atlanta to get care almost under any circumstances. Like, they just will not do it. And I don't remember.
SWATs. Yes.
Yeah.
I don't. I went to college in Atlanta.
Okay, so
Yeah, I know. It's true. Yeah.
In DC, it would be always the river. People wouldn't cross the river from Virginia into DC, even if they lived 2 minutes across the river. They'd rather go west into Virginia to see somebody than have to cross into the district. People do things that don't make sense sometimes, but whatever. That's what makes America great. You can make your choices and do what you want.
Yes, you can make every type of choice here. What tip do you have for parents and children when thinking about how they communicate with their pediatric surgeon? Like, what are ways they can improve their relationship, tell them what they're looking for, their outcomes? Because you know what, it's probably when you spoke really eloquently about the young parents meeting a new baby who needs help. They're probably not thinking, well, I'm going to be the driver of my child's care. They're probably thinking, how do we survive this moment to get to the next moment? And so I know, because needing a surgeon, like, even if you electively need a surgeon, it's intimidating. It's scary. Someone is like, you're going to pay someone to cut you open. I jokingly say that if they did that on the street, you would call the police, but instead you get you're signing up for it. And so it's intimidating. And it's also really just you're probably in a desperate situation where you're like, I am this sick. I am in this much pain that I am seeking, this type of intervention. And so what tips do you have for parents and how they think about and how they communicate with their surgical team?
Yeah. Well, I would start by saying, hopefully there are providers who are also listening to this podcast. And I think the providers, we often forget how intimidating we are, surgeons or otherwise, but especially surgeons, because we've been on, the media has portrayed us to be these, egomaniac, I can't remember the movie that William Hurt was in, but The Doctor, we've been made out to be these monsters, frankly. And some of us are, there's always some truth in stereotypes. But so if they're providers listening, I would tell them, remember that the people you're talking to probably don't know any surgeons, and they immediately go to whatever the media portrayal is of surgeons, and that's what's in their mind, which is why I try to break the ice with something that's completely more humanizing, sports or whatever else I can find that might break the ice, cultural, whatever, something that just makes it clear that I'm just a person and I'm not some technician that's just coming here to perform a procedure. So on the parent side, that is also still important. Remember, that you're dealing with a human. And sometimes if that human isn't maybe giving you the right vibes or the right juju or whatever you want to call it, it might be because he or she's having a bad day or whatever. Like, they're human, so don't necessarily judge them too quickly either. But you should definitely advocate for yourself and your kid. And you should ask as many questions as you feel like you want to ask. And if your surgeon doesn't like that, then you might have the wrong surgeon. And whether you have a choice in that or not, that's a different story. But no physician should be unhappy with a family that's asking lots of questions. Like, that's part of
I
what
agree.
we do, and we should be open to people questioning us. In fact, I used to tell people all the time, go get a second opinion. Like, I mean, for elective stuff, I'd be like, I will not take it personally that you want to go talk to somebody else to confirm what I'm telling you, because, that's what you should do, or go home and look it up on the internet, or, again, use AI if that's the way the world is going. I used AI to figure out what procedure my dog should get for his torn ACL. So, turns out it was the same thing that the veterinarian surgeons were telling me, but I just checked. I was like, I don't know, what do I know? But the point is advocate for yourself, and don't be afraid to ruffle a few feathers if you have to. Like, you need to feel comfortable with what's going on with you and your kid, and if that means speaking out a little bit more, then do it. And, hopefully the person you're talking to will understand what kind of stress you're under as a parent or as a kid. And, the goal for any surgeon is always really to help the person they're treating and the family if it's a kid. But, sometimes there are disconnects, but hopefully more often than not, you can really, forge some sort of relationship with your surgeon and feel comfortable that he or she is doing what's in the best interest for you and your children.
Ask questions, get a second opinion if you have the time and the ability to do so. And I like to give each other grace, and I think we as providers, we need to remember that you're often meeting people on their worst day.
Yeah. And sometimes it's the opposite too. Like, I have definitely met patients on days where I am just not in a good place. And I may not be nearly as good at showing empathy or tolerant of questions than I should be. Mm-hmm. So hopefully, and there've even been, I think, occasions that I can remember where I've gone back to patients the next day and been like, sorry, I was a little bit short with you yesterday because I was just having a bad day, and happy to answer whatever other questions you might have now because I didn't give you the time that maybe I should have yesterday, or something like that. Yeah. And so just, again, in general, people are too quick to judge others. So I always advocate for, you said it, you put it well when you said give each other a little bit of grace. Like, just give people a little bit of understanding if they're not quite what you had hoped for on your first interaction. And I think that goes both ways.
Yeah, no, it definitely does. If you can identify that you haven't done it well and gone back and ask for a second chance, that is an amazing feature. And I hope our people who are listening, med students, residents, whoever's listening, can know that it's okay to do it again. Like, it's okay to say, yesterday was not a great day. How can we realign? Because that therapeutic relationship is a relationship. It means that we do this back and forth. You ask a question, I answer. I ask a question, right? You answer. And
if there are times, which there can be, where the relationship is truly broken, then as a parent or a patient, you should see if there's an opportunity to find a new provider, but also vice versa. Like, if you as a provider understand that the relationship is broken, that's the time to ask your partner or your boss or somebody else in your group to say, listen, I didn't connect with this family. It's probably on me, but it might be on them. I don't know. But anyway, I didn't connect with this family. Do you think you could step in? Because I think it'll be best for everybody if you assume care or whatever. And I think we're too probably proud to do that most of the time. But I think, again, everybody's goal should be to just have whatever is in the best interest of the patient. So if that means you as a provider stepping out and letting somebody else come in, then do it. Like, just don't don't have the pride or the ego or whatever it is that keeps us from doing that from time to time.
Yeah.
Because I think, again, you just want the patients to do well, and that means also having a good relationship with the providers.
That's true. It's very true. So this is the part where I ask people about, you mentioned The Doctor. I actually recently just had a guest talk about that movie, where I say, like, if there's a movie, a TV show, a book, something that you would say drives home your message well, or vice versa, does like a really poor job of showing your message of how we should be communicating with our patients, what a pediatric surgeon, what a bariatric surgeon is, and how they work to help their patients, what would that be?
Well, my YouTube channel does a great job of showing
I love it.
what people should do. Like, you just go to my YouTube channel, you'll see
Yeah.
exactly how it should be done all the time. No mistakes ever. No, wow. Like, I haven't watched The Pit, although some people tell me it's great. I think if people want to see how it shouldn't be done, you could go watch Fit for TV, which is the Netflix documentary about The Biggest Loser TV show.
Yeah, I just watched that 2 weekends ago.
Not only did they really just do a number on those patients, on those people as individuals, but even the doc in that show, like, in my opinion, I don't know. I don't think maybe he truly didn't know what was going on, but I find that hard to believe, because how could you be a doc watching people lose 200 pounds with diet and exercise and not be suspicious that something unhealthy was going on? Mm-hmm. So I would say that might be an illustration of what not to do. And certainly don't yell at your patients like Jillian Michaels and Bob, whatever that guy's name is.
Barker?
Don't do that.
Bob Barker. I feel like that was like a game show host.
Yeah, Bob Barker is The Price is Right.
Okay.
But what was Bob's name? Anyway, but like, that's not a way to motivate your patients to do anything. So don't behave like that. And I guess, the other one that might not be my favorite way of doing it is My 600-Pound Life. Like, the way the surgeon on that show, is that the name of the show?
Yeah. Yeah, with Dr. Narweezen.
Yeah, Dr. N or whatever his name is. Yeah. Again, he doesn't particularly treat his patients very well, in my opinion. He gets results, I guess, but at least the TV suggests he does. I don't know how many good examples there are that are out there, because good examples don't make for good media. Like, no one wants to see
100% true.
Like, what TV show would be worth watching when the docs and the patients and everybody gets along and everything always goes right, and like it's some fun, roses and unicorns or rainbows and unicorns. Like, no, that doesn't make for good TV or good movies or whatever. So I don't think there are that many good examples. There are probably people who I could give you as good examples, but not necessarily in the media that I can think of. But maybe I'm
that's very true. No, you hit it head on, particularly around physicians' portrayal in media. I think it makes better TV when we're yelling at people. In reality, you get in trouble when you yell at people, right?
Yeah.
You get fired if you are problematic. But on Grey's Anatomy, you get promoted, And so it is different. And that's why I ask people this question, because if there's a good one, my favorite pediatrician or on TV was only a part of an episode on Scrubs where Dr. Cox takes his child to the pediatrician. And I just love that interaction of being a pediatrician to a doctor's kid. And, because he says to him, like, you have seen the worst. Like, your mind is going all these places, and as a parent, as a doctor parent, my mind goes all those places, and I find that our pediatrician, her job is the same thing, to like reel me in and tell me, like, no, they're actually okay. Like, that is what children do, and I loved our pediatric surgeon. He was everything that you could think of to be, not just with my very young child, but also, she was an infant at the time, with me as, a mom of an infant who needed surgery, who had 10,000 questions. And, all of those things. And so it's a special group, number one, who sign up to be surgeons. It's even more special
Special,
who sign up to
special in
be
quotation marks. Special or like or special.
yeah.
Probably both.
It
I think it's
is.
probably
It's like
both.
it's a skill set that like you have to learn. There's so much that goes into being a good surgeon. So much that goes into being a good surgeon. I had a surgeon speaking to me about the endurance that she needs to get through surgery. And,
Yeah.
she had an injury and she was training herself to be able to get back in the OR, which meant she had to get into the gym. And I was like, man, if I wear like a wrong pair of heels, I can sit down. You guys don't get that option.
Yeah.
And then
Well,
I
I
get
think,
to say like, okay, I'll wear something different tomorrow, but there's the technical skills that go into it, then the people learning skills, the research. It is a very special group of people who dedicate themselves to surgery, and then to dedicate yourself to the surgery on our children. And then dealing with us as parents. Almost every pediatrician I've had who's come on has said, if you don't love parents, don't go into pediatrics. If you're just in it for the kids, that's not the whole picture, And so,
yeah.
you said that you've taken the time to go back and say, hey, can we do this again? And so, if you're ever in a position where you need a pediatric surgeon, know that you should be asking questions. You should be, supported to ask questions and everything
Yeah.
that Dr. Nadler has shared with us today. Dr. Nadler, this has been a great conversation. Thank you so much for your time. Thank you for all of your work that you've done for patients and their families over the years, and being a part of trailblazing into pediatric bariatric surgery, and also working on expanding access to care through telemedicine. You're out there doing amazing work. And then you found time to talk to little old me. So I really appreciate it. I do. I really
Thank you for
do.
that. But, I think like people go into medicine for all kinds of reasons. And I think most of us go into it because we like dealing with people and we like helping people, and we get gratification from helping people. And, and I'm no different. And I just feel like now I'm just trying to help people in a different way than I was helping people, 2 years ago. And, hopefully people are listening and are learning something and helping make the world a better place, which sounds syrupy and sappy and all those things, because it is. But that's truly I think that's really what a lot of our goals are, is we just want to help people and make people healthier. And with respect to this podcast, you're just trying to help people when they hit a hospital not be as apprehensive or stressed out or whatever, and trying to give them some insights into what they might encounter. And that's great. And I think that's why, why it's important for me to be on here and everywhere else, is just try to help people get more information, because, education is power, right? That's like one of those sayings or something like that. Knowledge is power. I don't know. There's some
Power.
saying some saying that I'm getting wrong. But that's the point. The point is let's educate people and let's give each other grace. I like that. I'm going to steal that. There are a couple things you've already.
Take it.
I'm going to steal nocturnist. I'm going to steal.
You can't steal it. It's like a thing. You can't steal it.
Stealing it anyway.
That's an actual job. So,
Just not one I ever heard of before.
well,
I'm going to call myself that. I'm a nocturnist.
yeah.
No,
Well,
anyway, the point is
this is a
that,
ton of fun. Yeah.
yeah, and I'm happy to do it again sometime, and hopefully your listeners will keep tuning in and learning more about life in the hospital and everywhere else.
Yeah. Well, thanks for that. Thanks everyone for listening to another episode of the Prescription for Admission podcast. Today we had Dr. Evan Nadler here as our guest, talking about pediatric surgery, and taught us a little bit also about pediatric bariatric surgery and obesity medicine. I am your host, Dr. Monique Nugent. Thanks for listening. You can always check me out on my website, which is drmoniquenugent.com. Dr. Nadler, where can listeners find you?
So thank you for that. So obesityexplained.com is my website, and it's also my YouTube channel. And I actually don't even care if you email me directly. So it's, if you have questions, it's evan.nadler@EPNMD, which you can sort of see below my name. That's my initials. And mycredentials.com. So I am happy to help anybody who needs help in any which way, form they need. So reach out.
All that will be in the show notes as well, including your email. If you're okay with that, we'll stick that in the show notes. And yeah, you can come back to another episode of Prescription for Admission on Spotify, Apple, anywhere you find podcasts, YouTube as well. Please check out Dr. Nadler's YouTube channel, which is a wealth of information about obesity medicine. Please take some time to check that out if you're interested. And like and subscribe and come back for another episode of Prescription for Admission. Thank you so much, everybody. Have a good one. Bye.